ICP. So just this is in essence what is Monroe-Kelly hypothesis. I'll come to it in a bit. So just to recap this concept, the integral components are tight and just minor tweaking of one or the other can be utilized, and also is the basic pathogenesis. Until a particular stage, the volume is reflected without change in pressure, but as the components dictated, the pressure goes high and herniation can happen. So translated back in terms here, you can see this is what Monroe-Kelly doctrine is. So the volumes of different components are tightly planned and for utilizable physiology. And when any one of it, for various pathological reasons, alters, compensation should happen with the other component. If that fails, the raised ICP happens. So such alteration in the components can be handled, and that's what therapeutic interventions would be. So you get this concept while I move for case discussion. The first case was a case of subdural hygroma. I will explain about the case evolution, how it happened. It was a 6-month-old infant with a recent past history of acute GE a week prior, presenting with multiple episodes of vomiting, irritability, lethargy, and reduced urine. The examination showed a bulging anterior fontanelle. There were no focal neurological signs. The child was irritable and lethargic. The investigations were equivocal. CRP had a very high range, 257, whilst procalcitonin was in moderately elevated range. All the other multi-organ assessment revealed nothing specific. Ultrasound abdomen was done to just rule out intussusception, which was ruled out. Neuroimaging did not reveal much in the USG skull, but CT brain, which was done with us, showed bifrontal and interhemispheric CSF space widening. And a later CT done in the tertiary center showed leptomeningeal enhancement, but subdural fluid accumulation. The CSF, which was done later, showed pleocytosis, no culture, whereas the blood culture, which was sent before administration of antibiotics, grew Salmonella species, which is pan-sensitive, but with a minor resistance to mainly aminoglycosides. The treatment started with Ivextrak, ceftriaxone, and vancomycin with us, which is later managed in tertiary care with the tweaking according to the sensitivity, which required until about 4 weeks of IV antibiotic course. The crux here was fluid accumulation in the subdural space, which was the twist in the manifestation. The initial CSF showed no growth, whereas it was drained by lumbar puncture, but we were seeing repeated accumulation in the subdural spaces. The initial subdural drainage was done, and partial resolution was achieved in the subsequent week. As course proceeded with continuation of antibiotic course, the reaccumulation of fluid was noted. So repeated drainages were required by burr hole, and after 4 weeks of antibiotic course and probably 3 burr holes and drainages, the final resolution was achieved. So this was a Salmonella bacteremia with secondary intracranial complication of subdural fluid accumulation. This is a not so common complication, but this is what was presented to us and was a very challenging case. So a brief about what exactly this was, the imaging in our center. You can see this was reported as probably normal in the age, but as the case progressed to severe lethargy and it was sent as possible septic shock and meningitis. But later, as they proceeded with further investigations, two two distinguishing features. What is subdural hygroma and what is subdural empyema would be the CSF drain from these spaces. If they reveal pathogen, it would, and purulent composition, it would be subdural empyema. Whereas reactive, it does happen in situations unrelated to the pathology here, like say in our case, a salmonella bacteremia, where reactive subdural fluid accumulation, that would be subdural hygroma. So this case, if there is no leptomeningeal enhancement, it would be subdural hygroma. This was how it was sent from us, but later it seemed to have suggestions of subdural empyema. So that left the course to be as progressive and required interventions like subdural empyema. So this is how we see in the imaging. What is accumulation with epidural would be lenticular. What is accumulation with subdural would be crescentic, and subarachnoid hemorrhages would be curvilinear or like serpentinous. So for us to recognize in a CT scan an accumulation which is crescentic would be subdural. So there are literature reviews which with similar connotations. So in pediatric age group, certain infections, particularly with salmonella in different cohorts of population, it has been published, and we can see such literature. So what the pathology here is the trigger pathogen or even trauma, if it distorts the barrier here or triggers the arachnoid granulations to over-secrete the accumulations in extraaxial spaces of CSF. This is how it happens. As I said, if it is also pathogenic accumulation of septic contents, it becomes an empyema. A transudative composition would be a hygroma, whereas purulent, along with meningitis and accumulation of purulent contents, would become empyema. Our case navigated between the two zones, and eventually neurosurgical interventions and antibiotic treatment salvaged the patient. Second case. This was the case discussed in our last case discussion, 8-year-old. The reason I've included, I will summarize certain aspects which are particular focus in the follow-up and with the scope of IIH, which with the scope of raised ICT, which interventions are required. This was pre-pubertal, non-obese, otherwise well child, presented with headache, neck stiffness, diplopia, and episodic febrile phase in the recent past, had lateral rectus palsy of left side, bilateral papilledema, no focal neurological signs, only a few equivocal non-pattern signs. Lab, CBC, LFT, TFT, RFT, vitamin D, ferritin, non-contributory. So the crux here was MRI drain, supportive of idiopathic intracranial hypertension, including flattening of posterior sclera, distension of perioptic subarachnoid space with optic tortuosity, narrowing of bilateral transverse venous sinuses, no space occupying lesion, hydrocephalus, or meningeal enhancement. This is the dandy criteria where you will see all the signs and manifestation raise ICT without any focal involvement or hydrocephalus or infection like meningeal enhancement. The CSF study, there was no pleocytosis, was not done with us, was done in the reference center. And the opening pressure was told to us from the parents was somewhere between 40 to 45. Management, they started on acetazolamide. Serial CSF pressure monitoring was planned if symptoms worsen. This child happened to have gone to NHS, and that has happened, and the repeat CSF tapping was necessary from what we last heard. The final impression was the idiopathic intracranial hypertension with classical neuroophthalmic signs, that is papilledema, cranial nerve 6 palsy, MRI supportive features, and elevated CSF opening pressure. So this case we have discussed. The reason I happen to show you here is to show certain things which were necessary, which are necessary, and in subsequent cases, we have utilized it. Whenever we do lumbar puncture, associated CSF manometry is clinching in diagnosis. Opening pressure, about 25, is essential in diagnosing. How we do it is we can see this is a manometer. We will attach a three-way, and the lumbar puncture needle and the three-way with the manometer should be perpendicular to the bed surface and perpendicular to the surface of lumbar puncture. So this is how it has to be done. And the three-way cog helps you to swap between collection and monitoring. So once you attach it, you would see the opening pressure first. Afterwards, you would do the collection. So you attach it and see the meniscus on the level. That would be your opening pressure. And you tap it to a reduction of the pressure to at least normal pressure, which would be 25. If it is extremely high, there are 2, 3 different recommendations. You do not drain it to normal pressure. That would be a gradient of more than 30 or 40. You do it in staggered fashion so that it doesn't cause a lot of post lumbar puncture headache. So this is one of the things that I wanted to show. This, we have done it for other cases, but this was done in another center. Other things which are necessary to monitor would be the field assessment. A field characteristics which are known with IIH would be, this is the normal field where the blind spot. There will be an extension of blind spot. This is an enlarged blind spot, or something called as nasal step, or tunnel vision, constricted visual field. So this will be useful for us to progressive screening after an intervention, so that if it is necessary to make any visual salvage interventions in between. So this is the main current evidence to monitor vision. This would be a surrogate one. So optical coherence tomography. This is essentially like a ultrasound of the optic head with light. So this will be, it will tell the thickness of the retinal fibers and the accumulation. So this was pre-treatment, and post-treatment, we can see the reduction. So this is something which is, this is infrared. So this is apparently the current way of monitoring and intervention dictated by a particular range where we cannot compromise on the vision. There have been, how we zeroed in on acetazolamide, which has been a recent landmark intervention dictated about in adults extrapolated to pediatrics. This is one study where all the interventions were studied head on. Acetazolamide, furosemide, spironolactone, topiramate, they all marginally reduce ICP. Their effects were not greatly significant. This was a physiologic study which measured by telemetry the ICP when the patients were on a stipulated period on these interventions. And interestingly, the side effects known with these interventions were documented. Most of them had side effects. The predominant one were acetazolamide, which had certain cognitive deterioration, jump in certain cognitive measures. So still the search is on for the optimal intervention. So the search that is on is there is a good result in glucagon LPIR agonist, which is basically with associated obesity in adolescents and adults. And two other very important trials that are going on again with obesity IH, the bariatric surgery and the side trial, the weight trial and the side trial. In the side trial, it is a common, along with medical therapy, ONSF, the optic nerve sheath fenestration, and BP shunting. The case, you can imagine, the case gathering has been phenomenally difficult despite the case incidences increasing. Yet we are hopeful of getting the good evidence base from these ongoing trials. The next case, IIH mimic viral encephalitis. This is a 12-year-old girl with a presenting complaint of non-remitting fever headache, relieved by NSAID headache, neck pain with restricted movements, giddiness, and ocular pain. She was otherwise ambulatory and she didn't seem like she has any other problem, but she had this constant neck pain, headache, and fever before a few days of presentation. And that's the only reason she came, although she was tolerating the other symptoms. She was febrile, the stable vitals, vision normal. There were no neurodeficits. The HMF, coordination, sensory motor, all normal. There were no meningeal signs. The labs all were equivocal. MRI brain was done before CSF analysis. MRI brain, this is another sequence in our anticipation action plan we will discuss further. MRI brain showed posterior sclera essentially normal, but few changes of raised ICP with posterior sclera flattening, tortuous optic nerves, and optic nerve sheath, which is equivalent to ONSD, and few features of raised intracranial pressure like these. There were no space-occupying lesions. There's no midline shift or hydrocephalus, exactly fitting all the Dandy-Walker criteria of raised ISS. She was post-pubertal. She was pubertal. She was not obese. She had signs and symptoms, no trigger medications or obesity, and suggestions of raised ICT in the picture so far. The MRI neck was also done because of the neck movement restriction, which was normal. The focus done to check on, this is one of the revealing things, focus done on to check for ONSD reveals 6.2. Anything above 5 in an adults and adult range is considered equivalent to raised ICP. Then it was planned to go ahead with CSF analysis and CSF manometry, basically, like how I showed in the previous picture. It showed an opening pressure of just about increased 25 to 27 opening pressure. The revealing thing next was the CSF analysis. There was no pleocytosis, but the PCR we sent showed positive for enterovirus. Post-LV progressively resolved, asymptomatic by a week. Actually, by a day or two, the headache disappeared, neck movements started getting better. Off-the evaluation was sent, which was reported normal, which was basically not much of field assessment is being done with our off-the. But if we include ONSD as a part of assessment in ophthalmology, it was elevated. So what this was we were contemplating a case of IIH, but in the Dandy criteria, we got an etiology. That is the CSF showing enterovirus, and the resolution was dramatic within hours and days of intervention, if we can say that. So the impression was viral meningitis enteroviral presenting with raised ICP pictures and radiologically mimicking raised IIH, but resolved within the time frame of probable incidental viremia. So this is the ONSD of this child. ONSD is an ultrasound of the eye where 3 mm behind the optic head, we measure the nerve sheath diameter, which is about 6.2 mm. So anything under 5 for a normal adult or for a child, 4.5 is considered normal. Elevation, this has to be done in different planes, both eyes and the average is taken, is one of the bedside tools to assess the raised ICP. So the literature supporting this particular thing, the message here is enteroviral meningitis can mimic idiopathic intracranial hypertension. Although it is used to be called benign, it is a very gross picture of detrimental to vision. So it's no longer called benign for that reason. Whereas an etiology like this is something which can potentially favor good outcomes within no time, like we saw in our case. So viral induced intracranial hypertension mimics pseudotumor cerebri, and the trajectory is way different. So if we do this identification, we would not subject for unnecessary further investigation or planning for monitoring and treatment like how we would do for IIH. So be conscious of this fact. There are other couple of viruses which have manifested with similar picture, and those are the global evidence base for literature available in this direction. So what the point I'm trying to make here is, in the setting of IIH that we happen to evaluate, just go further and make sure the CSF analysis is done. And if before terming it IIH, do viral PCRs, this would reveal a different trajectory for the course in case if it is viral, most of the self-limiting viral encephalitis and such. The fourth case, an infant IIH. Patient was 7-month-old, acute febrile illness, poor feeding, bulging anterofontanel, notice even address. Other history, vaccination, and development milestones were age appropriate. Examination, the vitals were stable. The child was irritable, but interactive and consolable by mother. Systemic examination was normal. Significant bulge was noticed in anterofontanel and even at rest. There were no focal neurologic deficit, and that was of recent onset. That was basically the concern, raised bulging AF, irritable child. Investigations were done, working diagnosis of meningitis was made, and investigations were done. Most of them revealed nothing much. They were non-contributory. Neurosonogram showed nothing, no evidence of bleeding. Normal CSF analysis. CSF is done, no pleocytosis, PCR panel negative, unlike the previous one. CSF opening pressure could not be done. It's difficult at this age to evaluate that. That was, we had the surrogate of the drop count, which of course was not really rationalizable. And MRI and ONSD were revealing here. I'll come to it in a bit, which was suggestive of IH. So the whole panel, whole historical suggestions were like meningitis. CSF was not suggestive. The course and other features of imaging were, which I'll describe, but suggestive of IH. The treatment was started like meningitis, but stopped after other conclusive investigation suggestions. The child was monitored for ONSD because that was one suggestive thing, and it seemed to persist in the same range even after first week follow-up. So this was a case. So this is the MRI. The frontal and anterior interhemispheric CSF faces were widened. What happened was, after our lumbar puncture, also the course started getting better, clinically well, and all other interventions were stopped. Only thing that was persisting was the ONSD, which was wide for age and definitely wider. There was tortuosity of the optic nerve and flattening of the sclera, which are all indicative of IIH. So this was a case of IIH, which is very rare in infants, and I'll come to the literature in the subsequent slides. And there were no causes revealed, although the minor suggestions of febrile illness trigger was suggesting a possibility of viremia or, like a previous case, of viral meningitis, which were all ruled out, and a definite documentation of ONST. This child did not follow up later. The course expected is like IH, the vision needs to be protected. So it was very important for us because this is a uh, pre-verbal age where the child will not manifest with symptoms. So we had to focus on monitoring. But then the child did not follow. Otherwise, the complaint for which the parents brought the child, the demeanor and the recovery were satisfactory, and the parents did not follow up later. So, what as a evidence base, one of the case reports, one of the reviews, infantile IAH, it reviews about 26 cases globally. That's the latest one, saying only around this. They had to manage with acetazolamide, and vision could be preserved. This is the summary of many of the literature we have. Two or three other summaries suggest observing with spontaneous resolution also. So this is basically the same IIH which we have seen so far, but with which doesn't have a definitive etiopathogenesis in the exploration that we did so far and in the documentation. But one of the opportunities to salvage a vision, that was what we had, and we did intervene on those lines. But unfortunately, the child did not follow up much after that. The next case is a case of refractory status epilepticus, which was later in the tertiary centers told to be Adam. This was a 2-year-old child presenting with with a recent history of acute GE resolve, trivial fall at home followed by sleep, on waking, focal tonic-clonic convulsion, later unresponsive with ongoing seizures, and this is how brought to us. In the ER, unresponsive, normal equal pupil, status epilepticus on arrival. So acute management, diazepam, metazolam back-to-back, no resolution, had to do RSI, propofol, lignocaine, atropine, fentanyl, and intubate and ventilate. Subsequent anticonvulsant, levetiracetam, phenytoin, and super refractory had to go to metazolam infusion. The point here is we added a 3% hypertonic saline because around the time everything else is okay. We had stable hemodynamics, ETCO2 in 35 mmHg, and ongoing despite titrating metazolam to a higher range. Most of the investigations were non-contributory. The CT brain, which was done to rule out the possibility of TBI causing the picture, did not reveal any focal lesion, but suggested a possibility of diffuse axonal injury. ONSD at that time, 6.4, very suggestive of ongoing cerebral edema with the status epilepticus. That was the point of putting the discussion here. The MRI and MRV, which was done later in the tertiary center, showed some right temporal focal diffusion restriction. CSF done by the tertiary center revealed normal CSF, PCR also negative. The GI panel was done to explore etiology, which could possibly be the trigger, which was a non-specific astrovirus. But until then, the progress was they had to maintain the anticonvulsants and anti-edema measures for another 2 days and ventilatory care. One of the investigations they intended to do was anti-NMDAR, which could not be sent. The further course, this was the CT scan with us, which suggested a possibility of diffuse edema, no focal changes or midline shift, which ruled out the trigger of TBI causing the issue. Then we had started the initial therapy of ceftriaxone. They continued anti-edema therapy and ventilatory support, as I said, which was empirically started, but most of the investigations did not concur towards those suggestions. Then empirically, since they couldn't do the NMDAR, we did high-dose methylprednisolone, which within 2 days, dramatic response was seen. All the anticonvulsants and ICP interventions, everything were withdrawn within subsequent days, a day or two. They monitor this in the ER transit time. Our monitoring was, as I will subsequently say, the critical interventions which require monitoring of raised ICP would be sodium, ATCO2, ONSD. So these are available bedside and by point of care investigations and would assist in tweaking the interventions. So we can see the ATCO2 here maintained. This again is one of the useful markers to keep the CO2. We understand how CO2 alters the ICT, that in the subsequent physiologic discussion, I'll tell you, this was one of the things, and the ONSD, which assisted us to navigate the associated raised ICT. However, there is no protocol of addressing cerebral edema as such in status and superrefractory status. As an adjunct, it is utilized. But going on propofol or midazolam in itself is an intervention which will address the cerebral edema in refractory status epilepticus. The next case is, I will discuss the literature of all these cases together, was a severe DKA presenting with cerebral edema. Severe DKA most often than not is already associated with cerebral edema, and we will see how our case manifested. It is a 22-month-old IDDM with the first manifestation severe DKA. Post-initial stabilization with 10 ml per kg saline, the parameters were a pH of 7.08, a PCO2 of 6.6, and a bicarb of 2. We can imagine this much hyperventilation, how much cerebral ischemia would have already been the presenting manifestation. The glucose was 700, initially high and not recordable also. Potassium was 5. The renal function was normal. Insulin drip and protocolized management was started. A sequential fall within an acceptable limit of glucose, pH, and bicarb correction did happen in the guide rail zone. The point here is the cerebral edema and cerebral injury in DKA are almost coexistent with very severe DKA. We always see subtle life-threatening CA only in a few cases, but this is all these. The cerebral edema and cerebral injury are distinguished in DKA. The subtle CI is always there in most cases that we encounter. So what are the things that we need to keep our focus on when we are treating DKA would be, one, most DKAs, if they manifest with cerebral edema, do manifest within the first 24 hours. Later, very few cases is one of the studies to show hours of initiation of therapy, how within the first few hours is what you will get, and the later ones are very far and few. The second fact that one needs to know here is the debate between what is the intervention when you actually see cerebral edema, which requires intervention in DKA. The debate has been on about mannitol and amongst the hyperosmolar choices, the mannitol and hypertonic saline. And there have been no RCTs to suggest which is the better choice. We can see that the inclusion of hypertonic saline has increased. Both together has been the common trajectory. One of the large cohort, although retrospective study, revealed that using only hypotonic saline or ratios higher mortality. This is all the evidence base that we have. And with that suggestion, mannitol was a preferred choice. Although the RETA guidelines suggest one of the two, whichever your hospital is comfortable, one of the two could be used. The basis of discussing this is for the choice that we make, as well as the fact that there is coexistent edema. There's another study, the Pecan study, which really told us that it's not the treatment that is causing it. This is an intrinsic thing. Before we had this imagination about being a very stringent about what is the kind of fluid that we will be using, and hypotonic saline, all have been compared at the rate, the tonicity, and Pecan gave us that RCT information, which is a higher evidence form, where none of it matters. It's the fact that the already existent edema is what is manifesting. However, what we need to do further would alter the course of the event, so we will need to have a handle on that. So here, our case, as I said, amongst the tools we have is ONST. So this was pre-intervention and post-resolution. We can see this was in the range of edema, cerebral edema. The progression as the protocolized management subsequently followed. And the second day, it reduced. So what are the tools we have? The AVPU scoring, because an infant, it's very difficult to monitor. ONSC trend, sodium trend. These would be the surrogate markers which will help us to make a plan on whether the trajectory is instigating us to go for additional interventions along with the primary protocolized management. So here we had planned mannitol if there is a fall in the 15 AVPU score or ONS trend of increasing suggestions. Although this trend, we are aware anything going beyond 7 will not reflect the changes, but is already suggesting it's a feature of edema. And sodium, this is a very useful thing of the sodium levels. I will discuss how that is very helpful. In an older age group, the clinical symptom score for DKA would be useful as well. The neurogenic respiratory pattern would be suggestive, and monitoring the ETCO2 if already intubated would be useful as well. Incontinence, it's one of the major criteria, and very many studies have revealed the utility of this. Any resolving DKA, if there is a sudden incontinence in a verbal child and in a previously continent child, then you should think of edema and cerebral edema, and you should intervene. So any diastolic BP above 90, any age, and lower age group are all suggested criteria. So our baby cruised through the next hours with the primary management without requiring additional osmolar therapy. So the risk factors, as I said, we make a risk assessment plan. The risk factors would be high initial BUN, low initial PCO2, which were very high risk in our case. This would be the motivator for us to track the cerebral edema, which would require intervention. And if we have an age group where the symptom profile can help us, we would be making intervention. Whereas in infants and where you cannot track the symptom profile, The useful trackers would be the sodium levels and the EtCO2 or PCO2 levels, as well as ONSD if you have. So these are a couple of studies which reveal the utility of serial ONSD monitoring, which would help you use it as a trigger for intervention and sequential monitoring for resolution also. So this is the pecan study. As I said, it is really not related to the choice of fluid and the treatment flow and rate, which were all really something very, very important before. Now the focus is on the fact that if there are any risks previously suggested, that is the age and PUN and PCO2, be cautious of it because there is already cerebral injury. And as the treatment resolution happens, the osmolar fluctuations happens, is when the manifestation happens. And if there is a sudden fluctuation, that's why we have a guide rail as to how the fall should be, and that's the protocolized management. If we adhere to it, most times we would not have issues. And in cases where there are subtle manifestations and additional support of anti-edema measures are required, we should not hesitate to treat. Few things how EtCO2 or PaCO2 would be helpful for us to keep track. We know the component of the blood. If there is hypercapnia, there will be vasodilatation increasing this compartment. In the same way, if there is hyperventilation, this compartment contracts and it will be helpful in the treatment of cerebral edema. And about sodium, if sodium fails to rise, that is specifically in DKA, you should think of increasing the concentration of sodium. So this is the really useful marker whenever there is any brain injury by two manifestation, either by natriuretic peptide or by SAIDH, you will start noticing that the sodium starts to fall. So which is in itself a thing that triggers cerebral edema. So any neurocritical interventions or situations, if you notice anything going hypotonic, that is sodium going low, please intervene with increasing the sodium by any means, as in giving a hypotonic infusion, and if in emergency, intervene by hypotonic saline correction. The next case is a cerebral sol. There is not much about intervention here, but it's an obvious case of raised intracranial hypertension. It is a 6-year-old girl who presented incidentally diverted, self-diverted from BDF. They could not wait for CT scan queue. So they came over to avail the investigation to us, was presenting with right upper limb paresis and facial weakness with speech and mood disturbances, progressive mood changes. So imaging finding, you can see there's a large temporoparietal space occupying lesion, which is cystic as well, fluid filled. So the clinical impression was left hemispheric lesion causing contralateral motor weakness and speech mood changes in the temporoparietal localization. Neuroimaging needs to be characterized. This was the MRI. There is further characterization with diffusion spectroscopy that is required, as well as biopsy and intervention. So this was, of course, an ambulatory child with no other manifestations apart from these, but she was otherwise going about her normal physiology. But the only thing we need to be careful, simple Valsalva changes can tip off the pressure changes, and coning can happen. Although they appear to be, we saw the Monroe physiology, they are just about compensating, and something minor can even tip it off. That would be what our transit or stabilization process that we would be involved in. So this was sent for multidisciplinary addressing with neurosurgery, onco, and pediatric neurology, and we do not really have much follow-up on this. So what's our role? Anticipation and action. So children with any of these anticipated categories, can crash suddenly. So one rule, avoid LP. The others, cautious fluids. We have this knee-jerk rapid fluid boluses in our usual interventions. So be cautious. This could be a minor thing that can tip off towards cerebral edema. Then get a focus on having a control on the airway as early as possible in your clinical course. Then keep osmotherapy at hand, which would be mannitol or hypertonic saline. Use the bedside tools, the AVPU checks, DCS checks, or ONSD. The immediate actions, as I said, was ABC, and the ICP control, I will tell you. Airway, that is, it should be normoxia, no hyperaxia or hypoxia, and no, avoid hypercarbia. Hypercarbia, what it causes is severe vasodilatation and increase in the ICT. So circulation, you also need this a delicate balance between perfusion pressure and the ICP. So you will have to maintain a map. Any circulatory, any interventions, that's the reason mannitol is falling out of favor, because it can cause asthmatic diuresis and fall in the hemodynamic stability, which will lower the MAP. When your intervention has controlled the ICP and lowered the MAP, it is self-defeating. So you will need to have a maintained hemodynamics. So other ICP interventions, 30-degree elevation, osmotic therapy, control the seizures. Seizures in itself are a real trigger to generate cytogenic edema, cytotoxic edema, and cause further worsening of cerebral edema and ICT. See, be aware of the herniation signs, that is the pupillary, mainly the pupillary changes, coning, and the posture changes. So whenever you have any suggestions, we should act immediately. And what that act immediate, I will tell you. So just a word about avoiding LP. We all know this, that this is one of the interventions that we should be aware of. You do LP, you do imaging before LP in these situations whenever there is a trauma, whenever you're having associated support like the ventilation or hematology support or hemodynamic support, and papilledema, altered sensorium, seizures, and focal neurological signs. These are your indications where you wouldn't really do the LP first. You, although the indications will be necessary, you would do imaging before LP. So what are there are situations where you will not know ICP, and it's a critical associated clinical manifestation, which if you do not identify, it is life-threatening. It is as well as residual neuro damage, which needs to be avoided. So there are indications where you will have to monitor. There are the cases we saw, we had an insight to consider intracranial pressure, but critical cases where it needs to be monitored are in TBI. In fact, you will have to monitor invasive intracranial pressure. Most of these are TBI and such. Here, there are ancillary measures which will help monitoring, where the benefit of invasive monitoring has not been documented. So what is invasive monitoring? This is called the bolt, where you use a bolt which will monitor by inserting it in the brain parenchyma. So this probably would not be necessary. As I said, there are only certain cases, but it is really important, and it will salvage both the life and the neurological damage. The other means of monitoring include a couple of which we discuss now. Some are static and a snapshot view, some are monitoring. The CT and MRI and ONSD are the ones which are routinely used, which can be extrapolated for monitoring purposes as well. And transcranial Doppler is another one, which is of one of the neurocritical markers, which is currently utilized. What do we see in ICP and CT scan? You might see diffuse sulcal effacement of basal systems, which I showed in the first illustration, or enlarged temporal lawns are the frontal horns, and there are specific objective scores for that, and any midline shift and herniation signs. These are the grades of raised ICP in the neuroimaging that you would observe. And it's also called as a Marshall scale, which is again similar thing with more objectivity included. What are the current treatment modalities available? Let's discuss some with the background of Monro-Kelly. Methods for reducing include both medical and surgical. We know hyperosmolar agents, which will draw water from brain into intravascular compartment, thus reducing the volume occupied by the brain's parenchyma. Hyperventilation, it induces vasoconstriction, lowers CO2 of the arterial blood, which in turn changes the pH in the CSF milieu and causes vasoconstriction and decreases the volume of the blood compartment, arterial blood compartment. Sedatives and anesthetics is the mainstay in status epilepticus and such, especially the propofol and the barbiturates, along with the other intervention called hypothermia. They reduce the brain metabolic rate. This reduces all the metabolite accumulation as well as the blood flow and reduces the cerebral blood volume. So invasive measures like drains and punctures, it's no brainer. We understand it drains the CSF directly and reduces the intracranial pressures. When all these methods are insufficient, we may have to go for decompressive strategies like the Burr-Holzer craniectomy. So this we understand that the complaints can no longer be adjusted by adjusting individual compartments. So what are the evidence of various interventions? Many interventions that's far which we discussed, which are reducing the osmolar therapies are these, amongst which hypertonic saline is the usual suggestion. And here, globally, for different needs, both have been studied one against the other. And the 3% hypertonic saline is most in favor in most situations. The reason being, it does not alter the hemodynamics, whereas so it keeps where in situations with shock and unstable hemodynamics, this becomes the preferred choice. Whereas mannitol can induce AKI, acute kidney injuries in such situations. So your preferred choice would be this. Otherwise, head-on studies have been done with equal effectiveness. The side effect profile is what would make your choice more suggestive at the decision-making time. Anesthesia and sedation, these would be most important in the neurocritical situations of status epilepticus and such. Here, the monitoring becomes very important because we will, if one sedated and paralyzed, you will not be able to monitor with the usual signs. So, as I said, the surrogate ones which would be useful to monitor would be the ones which I discussed. Glucocorticoids in perilesional edema and infections are very useful. And as I showed one of the cases, in cases like autoimmune manifestations, high dose steroids are again very important in using for interventions. How hyperventilation helps. So this is one of the interventions. Once you have a control on ventilation, wherever there are such situations of impending herniation, you should be aware of utilizing this intervention. So how it is done, you should understand it's a rescue, it's a short-term one. Whenever we are in all the cases which we saw, we would possibly encounter a situation. If we have such a situation like impending herniation, these would be the clinical suggestions. any sudden deterioration or unequal pupils, or of course, we know the triad, Cushing's triad, you should be getting ready to have some definitive therapy in the background. What should be one of the two, or surgical decompression. You ventilate with a target of 30 to 35. Avoid going below 25. That's again self-defeating, as we saw, can cause cerebral ischemia. So we should do continuous monitoring of ATCO2 and blood gas. Excessive vasoconstriction causes ischemia, so don't go below this. Effect is very transient. It is immediate, but it wears off within 6 hours when pH normalizes. So what you should do is use this as a temporary bridge while we are parallelly preparing, and use it when you have impending herniation suggestions. So the take home here is many diseases, the dangerous pathway be aware of. If with the right anticipation, the right action, you can salvage. The physiology we saw mainly focus on the sodium, focus on the CO2. If you have EtCO2 as a monitor or a PCO2 in the blood gas, use these as your ballpark guide rails to whenever any of the clinical situations like a decay, a status, or meningitis and such. You use bedside tools like AVPU, mainly in infants. You will probably will not have anything else, but religious bedside monitoring of AVPU, just a fall from A to V or V to P, you tighten your antenna. EtCO2, we saw very sensitive for changes in the CO2 and sodium level. The cerebral in ICP changes are very sensitive, both as a physiological means as well as resolution means. ONST, until about a measure of 7, it is a trajectory which can follow the cerebral edema, and it's a very simple bedside tool. Utilize it, but know the limitations. Once it is reflective of resolution also, so it would be very useful to plan your interventions also. But the limitations is beyond a point, it doesn't reflect the increase in the ICT and the limitations of knowing the technique. Otherwise, is a very useful thing. So utilize your bedside tools, have your anticipation of where you could get these situations, and utilize the interventions to appropriate life-saving interventions. Thank you.
Thank you, Dr. Vanita. That was very, very exhaustive. Complete coverage of how many? 6 cases?
Yes.
6. We saw a wide range, ranging from pyogenic to viral to idiopathic intracranial hypertension, and metabolic cause as diabetic ketoacidosis and cerebral edema. So that was quite exhaustive. Thank you for bringing this very important topic to our on for case discussion. Any questions anyone has? So this close relationship between the close differential between IIH and viral meningitis and meningoencephalitis, which means the limited viral bacterial panel PCR that we have, if that is negative, it might still not completely rule it out, right? Because there may be a viral etiology,
the specific ones,
which is not
the
included in the
meningitis
panel.
panel.
Yeah.
Yeah. So the profile here has been the meningitis panel, but if we have other suggestions, the studies have been for the viremia, not the CSF viral panel. The CSF viral panel is configured over the common pathogens of meningoencephalitis. That the literature review has revealed herpes simplex, certain viruses which are not uh, usually causing meningoencephalitis, not included in the meningitis panel. So that is the certain case reports that I posted. But the message amongst all the reviews that I happen to gather, uh, IIH can be a mimic in viral encephalitis in the said etiology, like puberty, obesity. So we have all the determinants of IIH, but if we know that the trigger has been virus, pause and assess the viral causes. We also incidentally got this information, but on retrospective evaluation, this is what we gathered. And the global literature review also has happened in that direction only. So there is no recommendation as such, but this is a very revealing thing that in case you find this, uh, the trajectory is totally different. We saw dramatic response within days, which is not what happens with IIH. And so many times the residual effects of interventions itself linger on lifetime for these patients. So still active research is going on as to what is an ideal intervention in IIH. Although we started talking about IIH as a benign thing, it really is an ginormous thing as regards the impact it causes on the affected individual. So that way, so it's a really uh, a different trajectory it imposes once you identify this.
Yeah. I may have missed, maybe, but for all these cases where the raised ICP is a possibility, is a risk, what is the optimum positioning of the patient? Because I think these simple things make a lot of difference, right? So, did we talk about
Head
positioning
elevation,
of the head? Yes.
yeah, head elevation 30-degree is
Yeah.
the recommended thing. Which depends on the index case. So certain times ventilation would be the priority and the position needed for ventilation would be what your thing is. So depending on the situation, you can help additional posturing to reduce the acidity. In TBIs, it's a recommendation. Just first intervention would be to keep a
Elevate
head
the head.
elevated 30 degrees. Yeah.
Any other comments or questions?
Hello, ma'am. I'm Dr. Alvin, anesthesia. Yeah,
And that,
yeah. Good morning, everyone. See, when we keep the head in the neutral position, we are giving the nursing the child in the head and up elevated position. The neck should be also taken care of. There should not be flexion of the neck, in fact, so that the blood flow from the IGV should be through the IGV should be free. So the neck should not be flexed.
very right.
That is one
Yeah.
Thank you
thing.
for that.
And when we are doing the considering the rheological factors for the perfusion, in case the child needs transfusion of blood, when we think about the rheological factors, the blood viscosity, it's always better to keep the viscosity onto the lower side, so that the threshold to transfuse blood should be very high. In fact, so that a thin blood is better for perfusion in such a situation. So even a hematocrit of maybe around 27 or 30 will be adequate, will be better than having a hematocrit high value for such babies. That is another thing.
You
And
can give us a little more insight into the RSI and uh, ventilatory measures
yeah,
of
and
addressing
ma'am,
these situations.
yeah, you mentioned about NMD antibodies against the NMD, NMDA receptors. So once
Yeah.
I have seen such a case in which a teenage girl was presented with epilepsy, and finally she was diagnosed to have a teratoma, embryological tumor from the ovary, in which she was throwing fits for that. So we did surgery and we operated on her and removed the ovary, and she was cured of her illness. And finally, the anesthetic drugs that we tend to avoid in such a particular scenario where there are antibodies against N-methyl deaspartate are nitrous oxide, ketamine, and the new agent called xenon. All these three agents act through actually the NMDA receptors. And so when antibodies are present against that, these three drugs should be used with caution from anesthetic point of view. Yeah. Nitrous oxide, ketamine, and xenon. These are the drugs.
Okay, this is for NMDAR. In general, ketamine again is a avoidant thing to avoid when we concentrate ICP.
Yeah.
And what is the story of ketamine with us? We don't have them anyway, right?
Yeah, that's true.
Okay.
Hopefully, in one way. Thank you so much.
And what's the reason we do not have ketamine?
Maybe some procuring, maybe some difficulty with the authorities.
Not any specific restrictive implications?
Yeah, I am not sure of that.
Okay, because we haven't been having it for a while. Unless it's a major decision, we do not know why it's not there.
Grigori sir is also there in the group. I think he can answer probably.
Dr. Gregory, if you can. Okay, any other meet? So most of the next steps would be in assistance with anesthesia, and thank you for being with us to address situations. Amongst the cases which listed, there have been your support, which has helped us cruise through certain critical steps. One of them, the status epilepticus, the airway early and ETCO2 monitoring and propofol, midazolam, these were the interventions which helped us, and as well as in CSF manometry, you have been of our assistance. Thank you.
I have just one question regarding the CSF manometry. We need to attach the three-way before we
Yes.
before itself, right? Even before.
We should prepare the sterile three-way and the manometer and be ready. Once we do the lumbar puncture, we attach with the three-way towards the manometer, open towards the manometer, keep it ready. And once you open it towards the taps, we will do the collection.
So you will have to do it quickly, because when you normally there's the stylet, right? So you need to remove the stylet and immediately attach this. So there is some time lag between removing the stylet and attaching the three-way, isn't it?
The critical step there is make a slow withdrawal of the stylet while you are in the process of attaching. Yeah. So that has to be a little optimized. Once you drain a bit and then attach, you might
it will not show the opening pressure anymore.
Yes, it might still be a value in situations where it's really high opening pressure. That might not be a big deal, but the accuracy is your step of attaching the monitor at the as soon as we withdraw the stylet.
Right. Okay. All right. So I think if there are no more questions, we can close. And yeah, thank you. Thank you, Dr. Vanitha, and everybody.
Thank you all. We'll meet with the next month's CME. The first Thursday would be from an external speaker. We will keep you updated. Thank